we're going to go over some of the pearls of physical exam. And for all of us who take care of baseball players, the history in the exam is so important because the MRI always has damage on these players. And so learning where their symptoms are coming from, what's generating their problem, comes from the physical exam. And the physical exam is a skill like throwing darts. It is a skill. And so we're fortunate enough to go over some of the most skilled physical examiners and teach us some pearls. Okay, so let's get started. Let's get it going, Mark.
I'll start with it. Morning, everybody. As Chris pointed out, we really depend on the history and what our athletes are telling us to help us focus our exam. Rich Hawkins taught me to examine the knee and listen to the shoulder. And if you think about that, that's pretty wise. The exams we do on knees, the ligamentous exams, they're pretty specific, pretty sensitive. The stuff we do around the shoulder, not so much, especially, we're looking at labrums and those sorts of things. I mean, it's 2/3 at best. We really count on our history. And I think that's just a very important take-home point. What we're going to do today, I'm going to go through just neck and scapula stuff. And I think Tony's going to jump in and we're going to divide it up amongst a bunch of us here. So bear with us. So first thing we're going to do, when the athlete walks in the room, right? So we're going to stand up. So give Tony a workout. That's okay. So first thing we're going to look at is posture. Okay. Abba's got great posture, so we're going to look at him. Stand like face the nice people. Okay, very good. So we're going to look at him from the front.
Can you all hear him in the back?
Can you hear me?
Great.
Okay.
Perfect.
So we're going to look at him in the front. We're going to come around from behind. Look. Very good. Looking side to side. He's got upright posture. Got normal lumbar lordosis. He's got a great scar on his left forearm here from something. Head's pretty neutral, so cervical spine looks pretty good. So that's just a quick look at his posture. Next thing we're going to look at is just visible. We're going to look at his him for anything obvious in terms of atrophy, malposition of a scapula, AC joints, SC joints. So I'm going to take a quick look at all those things visually here. One of my partners can actually do the exam. We look at the cervical spine. We're going to check all ranges of motion. We're going to ask him certainly if there's any midline tenderness, no soreness anywhere in here. Okay. Tilt your head back. Okay, chin to chest. And look straight ahead. Turn your head to the right. Turn your head to the left. Okay, straight ahead. Now tilt this here that way. And then this here that way. If you elicit any symptoms, we'll go further into that, but that's just a quick, take a quick look at the cervical spine. And we'll look at his scapula here. Go ahead and turn around, please. So as you can see, his scapula is sitting in pretty good position. Oftentimes we'll see a little bit.
Can we get the camera right on his back, please? From behind the side.
If you move their neck and they have pain into their shoulder, does that mean something different if they have pain radiating all the way down into their hand?
Yes. I mean, obviously, when you're getting, there's not a lot that happens in the shoulder as primary pathology that gives you pain below the elbow. Okay. So if someone's got radicular pain, starts here, passes through the elbow into the hand or the wrist, we're starting to think about cervical spine as the etiology of the shoulder pain. If it stops at the acromion, maybe you're dealing with something at the AC joint, something along those lines. But primary shoulder pathology typically doesn't affect distal segments, but I mean, it can, MDI can do it a little bit, but that's beyond our scope of our discussion. So first thing we're going to look at is resting scapular position, okay? His resting scapular position here is normal. The throwing athlete, again, a lot of times you'll see what we call a sick scapula, where because of some tightness in the pec minor, other things going on, this scapula will actually sit down a little bit. So we're going to look at this statically first, and then we're going to have him move his shoulders. Okay, Abbott, raise your arms just straight ahead, up and down a couple of times for us. Okay, come on back down. So he's got nice, go ahead and do that again. Nice, what we call scapular rhythm, right? Everything's moving very smoothly. Do that one more time. So I'll have him do this several times. Okay, come on back down. Now I'm going to have you get up into like a throwing position. Okay. And we're going to do the same thing up here. Okay, so Go forward now from that position down, both of them. Good, and back. Do that again. He's got great scapular control. All right. Now, if we're looking for winging, there's different types of winging. You can have winging due to some weakness in the serratus, rhomboids, traps, those sorts of, so winging patterns are going to be different for all of those things. For me, what I do first, I'll have him put his hands on his hips. Bring your elbows forward. Okay, we're going to watch that. He's actually off a little bit here. See how this one's down a little bit on this side? Go ahead and bring this forward again. There you go. Now bring him back. Okay, forward again. Good. Back. Okay, come on down here. Now shrug your shoulders for us. Okay, back down. So that's traps. Okay, up. Okay, now squeeze them together from there. Rhomboids. Okay, traps, rhomboids. Serratus. Okay, come on back down. I'm sorry. Weakness in the serratus is going to cause medial inferior winging down here. All right. Trap is going to give you some weakness up top. Rhomboids, the whole thing's going to come. All right. So that's it. Questions about the scapula exam? Our next segment.
I think that's great. Let's, and thanks, Mark. Tony's going to go over some issues around rotator or instability rather that we can see in our outfielders and our position players and also in our pitchers.
So that was a great thing. And as Mark says, really one of the things we want to do is we want to just observe the athlete and watch some of these movements. And our eye is extremely sensitive to variations in symmetry. So if there's a slight difference in the two scapula, our eye will pick that up very nicely. And then we might go further, do measurements and other things so we can actually identify whether our rehabilitation programs are effective. When we're talking about instability, the most common instability that we have to deal with was anterior instability. But in baseball, we see a lot of posterior labral problems and posterior laxity issues that we also have to think about. So we really want to do a full examination. And I oftentimes, I'm going to have you come over here. Sorry, moving the camera spot. Go ahead and sit down for me. You want the patient to be relaxed. The athletes obviously have good muscle tone. They're going to make it more difficult for you to be able to gently translate the arm. And Mark already went through the range of motion, and then we start to think about anterior instability. We can look for signs of laxity. We see that in some of our players, especially some of our younger players. You can also pick up signs of laxity if they can hyperextend their elbow more 10 degrees or their knees. So we look for evidence that suggests they have overall laxity of the shoulder. And when we're looking at anterior instability in a sitting position, we can just bring the arm back here. In an athlete that has a significant labral tear or bony injury, which we don't see at the same level in most of our baseball players, you put the arm in this position, and as soon as you start to bring it here, they can feel there's something not right with their shoulder. We call that apprehension when they do that. You can also push back on the shoulder, and as you rotate it out, it feels more comfortable. And when you let go and it slides forward, that's a test that we can use. We usually do that when they're lying flat on their back, so that's a little bit easier for them to relax. And then again, just as the overall understanding of the capsular laxity, we do what's called a sulcus sign. So we try to see some separation here is normal, but if we start to see 2 finger breadths or 2 centimeters, that's not considered to be normal. And the other test that we can do is we can hold the scapula and bring the arm up, and it should stop at around 100 degrees, 95 to 100 degrees. And if it goes 10 degrees more on this side versus the other side, it's a good sign of inferior capsular laxity. And that's a Gauger sign. We don't use that as much in the United States, but it's really helpful when you're dealing with patients that have significant laxity, especially if they've had anterior shoulder surgery and they still feel uncomfortable. This test can be positive and solve the inferior component of the instability. With posterior instability, I know Keith has a talk on that. We typically use a test, and let's turn sideways just a little bit. And what we're trying to do, we call this the jerk test. We bring the arm up. We'd like the humerus to go below the level of the scapula. So you have to kind of hold onto the scapula and you push back, and that should sublux the arm in an abnormal situation. And when you rotate it back, it pops into place. Our young athletes can have a positive finding here. So what you want to do or hear is you do that and they say, oh gosh, that's it. That's what really bothers me. And that will tell you it's posterior instability. It's typically posterior inferior. Some of our athletes, if they go to the ground, put their arm out, they have posterior shoulder pain. It will hurt with this test, but they don't necessarily have a lot of instability if it doesn't go all the way down inferiorly to the lower part of their shoulder. We also look at the posterior labral tissues by putting them in this position, the labral slide test. So we'll go down here, and sometimes they'll feel it even down here, but when you get to about right there, that'll pinch that posterior labrum. So you'll hear about batter's shoulder, and that this scenario will really hurt to put them in this position, and it eases up a little bit up in here. And so that's another test we do for the posterior labrum. And the superior labrum, we typically look at.
Tony, just for time, we're gonna, Keith's gonna go over SLAP. Let's do latissimus, and then Mike's gonna go over some oblique.
So the latissimus, so as you know, it comes off our back and goes all the way up into a thin tendon into the medial aspect of our arm here. And so if it's at the end of the throw, it feels something happen. And it can be a pop, or it just doesn't feel right. Because what it does is decelerate the arm. That's when you feel the pain in latissimus. And typically, it's way up here, you have to really reach for it. And a lot of times, it feels that plenty of talk about the tendons are just right next to each other, but you can feel this tendon all the way up in here and all the way into the humerus. Ecdymosis or bleeding into this area. The teres major is right next to latissimus, just above it here, and the same thing. So you can have that push down back, and then push back. It's my hand, so put my hand like this.
That was terrific. Mike Reinhold, who's an exceptional physical therapist and athletic trainer, tremendous experience with baseball players. He's going to go over this elusive condition of oblique injuries that we see a lot in the high-level athlete.
Thanks, Chris. Yeah, for obliques, I think the exam's relatively straightforward. What I try to do is go through a sequential progression to see if I can provoke the symptoms more and more with just different activity levels. One of the first things we do is just talk about the location of the pain and palpate, right? And most times people are going to point right underneath that lower rib, and it's going to be a very isolated spot that we see pretty commonly in that area. If it's not there, we tend to think, is this another type of strain, not quite an oblique, but the oblique tends to be a little bit more off that lower aspect of the rib. So the patient will usually just point in that spot, we'll palpate, and then from there, we'll try to provoke it with some movements. The first thing we'll do, honestly, is just a cough test. And we'll just have them do a quick cough. You don't have to do that right now, right? COVID, we put a mask on first, but just have a quick cough and just make sure that that doesn't reproduce the symptoms. If it does, we'll usually use that throughout the rehab progression to see if that is improving. To be honest with you, the cough test is pretty quick and easy. But what we do first is a rotational test. So cross your arms over your chest for me and have you rotate to the right for me. And we'll just do that, just active range of motion, and see if we can get those symptoms. If it does or it doesn't, I'm going to still try to progress through the sequence, but I'll add some overpressure to it and see if that increases the symptoms. And then from there, we'll do a resisted contraction back into me. Good, just like that. So what I'll do is I'll actually put them in that resisted end range of motion, then contract. For me, I usually can tell the severity of that by which one of those hurts, right? So if somebody's okay with just active range of motion, but overpressure hurts, tends to be a little bit more severe. If somebody just hurts with just their active range of motion, I'm a little bit more concerned. Other than that, we'll do a side bend to the side away from the injury site. So if he's right-handed, it's usually the lead side. Cross your arms on your chest again for me. We'll just lean over that way. Same thing, we're looking for a stretch. We can add an overpressure and then a resistance in that spot. But between that and the cough test, and then what I'll actually show this in my presentation, I'm doing it a little bit later on oblique injuries, we'll do a resisted, almost anti-rotation press. I think we can get a good idea of whether or not this is an oblique and if this is going to progress quickly or not.
Oh, that's great, Mike. Okay, we're going to go into some more advanced exam maneuvers, particularly for the injury patterns that are most common. And so we're fortunate enough to have George Paletta and Keith Meister, who are really experts, together go over those fine exam maneuvers.
Morning, everybody. Actually, I'm gonna put you down in the supine position here. Yeah, my back flat. That's all right. Need a boom mic. The one thing we didn't talk about was range of motion, and I think that's absolutely critical. The way I like to examine it, always non-dominant side first, but we're going to go dominant side. And for me, always, it's a real pet peeve of mine, stabilize the scapula. Otherwise, you're really not getting an accurate assessment of the glenohumeral joint. So for me, I make sure I put my thumb down on the tip of the scapula and I get them in elevation. And I want that scap flat to the floor. I hope everybody can see me. And then I do the same thing when I'm doing IR and ER. I get them in an externally rotated position. I stabilize the scap, and then I'm feeling tension on the on the shoulder in rotation, and that's my external rotation measurement. And I do the same thing with IR. I actually stabilize the scapula and I bring them into an internally rotated position. And to me, those are the most accurate numbers that I use as assessment that I can use best when I'm comparing side to side. And I think that's the most relevant for looking at pathology. 3 things I'm going to give you here. Number one thing about the lat and the teres and the capsule and whatnot, I tell every one of my trainers, if a player comes off the field with deep posterior axillary pain, it's an anterior capsular tear or a lat teres injury until proven otherwise. They come off with acute deep posterior axillary pain. It's those 2 things until you prove otherwise. You never want to miss those 2 things. Sit on up for me real quickly. And then 2 other exam pearls, again, I'm going to give you. I think resisted external rotation strength is absolutely one of the most sensitive things you can do to a throwing shoulder. So I have them at their sides. I have them resist external rotation. And then I also want to know how they feel on release. So I'm looking at weakness, and I'm looking at if I can provoke any painful symptoms. And typically they're going to have referred pain. If it's significant cuff pathology, it's going to be referred pain more to the lateral and posterior aspect of the shoulder joint. The other thing that's important, if you know these athletes and they begin to have serial weakness in external rotation, it could be neurogenic, it could be fatigue, but again, another pearl, it could be a progressive, what we call posterior cable injury, where you're starting to lose the posterior cable on the backside of the shoulder, particularly with more veteran throwers, and that may be something structural that needs to be addressed. And then the last thing is lie back supine. My most significant go-to test for many, many years for significant cuff labral pathology is what I call the posterior impingement sign or internal impingement test. I bring the athlete into the provocative position, and I'm typically sitting in their axilla, but I like to put them in the arm slot position and recreate their symptoms. And if I can recreate their symptoms and they say, yeah, doc, that's it. That's my pain that I feel in the backside of the shoulder or deep in the shoulder. And then I can reduce their symptoms by reducing the point of impingement. To me, that is probably the single most important test that I do in these guys, because most of the time they're going to complain of either bicep pain, anterior shoulder pain, or deep posterior pain and leg cocking. That's going to take care of 95% of your diagnoses when somebody comes in with a painful shoulder off the mound. So
sit up for me. I'm going to review with you briefly the tests that I usually use for a slap tear. I'm going to preface this by saying none of these tests are pathognomonic for a slap tear, and there's still a debate as to whether an isolated slap tear is an adaptive change or, in fact, pathologic change, because there's often associated pathology. Unlike the pivot shift maneuver for the knee, there's not one test that really tells you that there's a pathologic slap tear. So these are data points in the overall picture of clinical history and your additional information, such as imaging tests. But I use 5 tests that can be done in about 30 seconds. Abbott, can you stand up for me? So I do 3 tests in the standing position. The first is a speeds test, and I do this in 2 ways. Speeds test is done with the forearm maximally supinated. Arm I bring at this point, and I have them actively elevate the arm up to the 90-degree position. I do sometimes palpate the bicipital groove, and then I ask them to hold here and give them downward pressure and see if that reproduces any pain in the bicipital groove or deep shoulder pain. From that position, I will then take them into the active compression test, which is also known as the O'Brien's test. When Dr. O'Brien first described this, he described very high sensitivity and specificity for this test, but other researchers have not been able to reproduce that. This test is done with the shoulder at 90 degrees of forward flexion, about 15 degrees of cross-body adduction. It's done with the arm in 2 different positions of rotation. Start with the thumb down. I stabilize the shoulder. I provide a downward force and see if that reproduces deep shoulder pain. They then will maximally supinate
in the same position of forward elevation and crossbody abduction with downward force. If they have reproduction of their pain with the thumb in the down position and reduction of pain or elimination of pain with the thumb in the with the arm supinated, that tends to indicate potential for a slap tear. If the opposite is true and they have more pain in the supinated position than in the pronated position, concern about the AC joint. And then from this position, I take them up and do a dynamic labral shear test. I bring the arm to about 100 degrees of abduction. I provide an anterior load on the humeral head, and then with slight compression, I elevate and shear on the labrum to see if I can reduce their pain. So done quickly. Hold here. Brian's test, come down. The Brian's test, maximum supination. Dynamic labral shear test. Then if you can lay down for me. Then there are two tests that I will do in the supine position. The first is a compression rotation test with the forearm in neutral, the arm at about 100 degrees of abduction. I will compress the glenohumeral joint and then rotate internally, rotate externally, slightly different than Keith's test, which gets them in maximum rotation. I'm trying to compress the labrum and shear on it to see if it reproduces pain. And then I'll move them to the biceps load 2 test, abduct them to about 120 degrees, neutral in terms of extension, maximum supination, and then have them go ahead and resist and see if that reproduces their pain. And those are the 5 tests that I typically use for slap tear. Again, none of them are pathognomonic, but combining those with the other findings on exam and the clinical history can help pinpoint whether this might be a slap tear.
George, Keith, fabulous, fabulous. Let me ask you before Abbott leaves, some of the tricky ones. Do you have a quick pearl on thoracic outlet that you can share?
Physical exam?
Physical exam, yeah.
Go ahead.
I do 2 things. Number 1, go ahead and lie back flat. I use what I call my provocative rights maneuver. And what I try and do, I really emphasize every time I'm examining a thrower, it's trying to reproduce what they're feeling off the mound. So again, with a provocative rights, I have them turn their head all the way to the opposite side. And then I bring their arm back into the extended position, and I always have my fingers on the pulse. And I try and find the point at which maybe I dampen the pulse most significantly, and if I can eliminate it completely. And always looking side to see if there's a magnitude of difference between the 2 sides. But again, anytime you examine a thrower, try and reproduce what they're actually feeling on the mound. So extension, and try and get that position at which that TOS or that thoracic outlet is going to be most aggravated. And then I do a standard ruse maneuver, which is arms up over the head and open and close the hands.
Oh, you okay?
And then I just hands up over the head, open and close, and usually I'll distract them and I'll just start talking about something else, and then I'll readdress in about 30 seconds. Hey, you feel a difference between the 2 sides? Or sometimes they're already provoked, whether it's numbness, whether it's fatigue, side to side, subtle side to side differences. I find that it can be very helpful as well. Good, relax.
The other test that I typically, we haven't talked a lot about palpation, but palpation is very important. And typically, if I have concern about neurogenic thoracic outlet, the 2 areas that I focus on and palpate simultaneously bilaterally are the anterior scalene triangle just above the clavicle and then over the pec minor. And if you can do that bilaterally, and if there's asymmetry, or if it reproduces arm pain or sense of numbness, and I'll oftentimes palpate and keep the pressure there for 10 or 15 seconds, and the same over the pec minor, and then I do the standard ruse test, and I do the same test that Keith does. I typically do it standing. I do all of it standing with the head, but the same test that Keith showed you doing supine to try and reproduce those symptoms.